All right, before we begin, how many folks use artificial intelligence to diagnose healthcare for yourself or others? Raise your hand nice and high. Oh, wow. Okay. Any favorites out of the 4 people that raised their hands? Use ChatGPT. Anyone else? Anything else? All right, well, this next session will be a conversation with myself, my guest here, and my guest on screen, talking about kind of taking a more specific look at what AARP first introduced earlier, the idea of utilizing and leveraging artificial intelligence in a healthcare setting in terms of diagnosis and care. Before I begin, I would like my guests to introduce themselves and offer a little bit of information about themselves. First, James Cummings.
Hi, my name is James Cummings. I live in Connecticut with my 3 children and my wife. My former life was a front-end digital designer, product manager, and I put that to bed 3.5 years ago after my second son was born with a separate rare disease from his older brother. And despite having different conditions, they had the same data problem. So I've spent a collective year worth of days in the hospital. And I've seen how the sausage is made between departments, between shift changes, and certainly between inter-system data transfer. And I knew what I was going to do with the rest of my time on the planet was to help improve the way that we use all the data that's collected on our behalf to better diagnose and treat for more favorable outcomes. So I immersed myself in the 21st Century Cures Act. I have really delved headfirst into standards development, and I understand that the key to unlocking all this data is through the consumer behavior. I recently published a paper called Consumer Data is the Key to Artificial Intelligent Benefits. Welcome to the Healthcare Future. I started a nonprofit called Participatory Health, which is designed around bringing use cases that showcase the consumer behavior, the policy, and the technology so we can leverage and access all the 60 zettabytes worth of data that we collect as a globe in healthcare. So I'm happy to be here and looking forward to a very good conversation.
Thank you, James. Now, Linda.
Hi, everyone. So sound check, hear me okay? Great. I'm Linda Travis Macumber. I'm a professor here in San Diego with National University, and so welcome to San Diego. I'm also been working in various flavors of health IT really over my entire career, starting as an ICU nurse at Boston Children's, grew up in Michigan, University of Michigan, but certainly in my, I think I feel like my career's sort of been an interoperability of healthcare because I've worked in so many different flavors of it throughout a lifetime. But a few highlights. Actually, at the next HIMSS meeting, I'm going to be honored as a Life Fellow. So, I mean, I've been around a long time and done a lot of things. But certainly, probably the most important have been the aspects that have really affected each of us, as patients, as individuals. I feel like that some of the early days of working with various electronic health systems, I had kind of either a ringside seat to the history as well as being a part of it, with helping to launch the Department of Defense systems that brought me to San Diego in the 80s from Boston, and on the original team of a handful of people that developed the system that's run through the Department of Defense for really the past 4 decades. So I guess if you look at the test of time, also led the requirements team with Kaiser Permanente in the early days, and really Kaiser was Epic's first significant, sized customer, and so many of those requirements have evolved into the Epic systems that you use today. Certainly the next generation of, but it's kind of fun to be on the forefront of some of these really incredible aspects of history, but none of them compared to today. And so I mean, I've studied AI in Boston in the 1980s, back with, Marvin Minsky, one of the original founders of the term in 1956 in Dartmouth, and have had the ability to meet with unbelievable leaders over the decades. So I'm just humbled to share a few words of wisdom as to, with that perspective of history. So worked with community health centers, with electronic health records, launching those, and led the Davies Award, for those that are familiar with HIMSS, chaired the Davies Award, and certainly have done some advocacy work through those years. But fast forward to really the current chapter of my career, I founded the Master of Science in Health Informatics program back in 2009, one of the first in the country, focused on health, not healthcare, not medical, not nursing informatics, but truly health. So much more of an outcomes orientation. And so today I teach graduate students from across the country. I currently have one in Hawaii, one in rural Missouri, one that's on a ship in the Pacific. So it's a fascinating opportunity to share what is new, what is working, and hopefully influence that as well.
Definitely. What's new and what's working is my next, I guess, the beginning of my next question. I'll start with James. From your research and your experience, definitely as a caregiver, what are you seeing in terms of the greatest benefits that folks are leveraging and utilizing with artificial intelligence?
So I think, if I alluded to this in my introduction, that the biggest disruptor for the current state of healthcare and medicine is not artificial intelligence. It's the consumer behavior that we are trending towards as a humanity. So despite not having medical education or experience, consumers have aligned intentions and ample time to think about their symptomology and their diagnoses. And that is actually where I believe the shift is going to start. And it comes from the desire to leverage that aligned attention and ample time, despite not having medical education or experience, and maximize the time between encounters that they have with practitioners. Now, previously, 50, 100 years ago, we were reliant on the clinicians to tell us what we had and what we could do about it. The shift happened in the early 2000s with the introduction of the internet, where all of the data that is available to a medical student is available to a consumer. And the advent of Dr. Google first showed itself. The new version, or the new acceleration of Dr. Google, is Dr. GPT. So it is an untiring, limitless, as I think I heard before, you can prompt relentlessly and never be a bother to it, and ping it incessantly about anything and any thought that you have in your head, where you would not be able to do with a practitioner. The average clinician sees a consumer between 10 to 12 minutes. And then after that encounter, what is the role of the consumer? And that consumer needs to activate their aligned intentions and ample time into some capacity. Their brain power needs to be put to use. And the introduction of GPT or large language models is really elevating that level of participation. And we're going to get into this. One of the biggest benefits of being able to ping or consult with this digital ally is feeding it the data that it needs, and the comprehensive, complete, up-to-date data that it can access to give you some sort of clinical vocabulary to go back to your consumer or your clinician and make the next encounter that much more productive, getting yourself to a more favorable outcome that you would otherwise not have had if you were not engaged with a large language model.
Excellent. With Linda, we actually had a conversation. The initial email when I invited you to be a part of this, you came up with a fantastic story, a true story, which is an example of what folks are doing now with artificial intelligence. Offer the audience that story, but then also offer your insight in terms of what have you seen in terms of the usage of artificial intelligence.
Sure. Well, I guess I'll start with the story because you guys have had a lot of stats lately. So that, so certainly I think everyone is on a journey of being just kind of an AI skeptic versus, an enthusiast. I'm clearly more the enthusiast, the accelerator, and other folks are more the brakes. But somewhere meeting in the middle. So imagine actually in conversation, I try to encourage as probably the professor that has students use AI the most, and to leverage it as much as possible. So, but certainly you never know who's listening, right? Sometimes the things that you share, you have no idea that they're going to actually help someone who helps someone. So that's, I guess, is my sort of life goal, that somehow I can do that. And sometimes you hear about it and sometimes you don't. But this time I did. So I was sharing different examples of using AI in healthcare as part of a graduate school course. And one student, unbeknownst to me, has an 8-year-old son who has been sick for 5 years, has gone to countless experts with no diagnosis that was correct. So, but used what she learned in class as being a mom as well. So we went through open evidence as well as perplexity, which is a big favorite of mine because it does provide evidence and references, as well as being able to access all of the different models, ChatGPT, as well as Gemini, Claude, et cetera. And so she learned how to use the models in class responsibly. Meaning, so even when entering patient data, even though on the interim level, it shares it with the models, you can set and configure it so that if you're putting, personal health data in, that it's not permanently training the model. So she felt comfortable enough to actually do that, put in lots of information into some of the perplexity, open evidence, ChatGPT, different models. It came up with a diagnosis that had not been considered. We often focus on errors of commission, medication errors, and other things, but think about the cost of errors of omission. We just didn't get it early enough, or we just didn't think of that because we're so hyper-specialized. But she brought that to her physician, ended up being correctly diagnosed with a rare condition. The kid is now doing great. So, I mean, it's sometimes it's the diagnosis that is difficult, and the treatment can be fairly cost-effective and easy. But if you miss the diagnosis, the costs are incredible. So I think that the insight there is to consider all options. But I think it's also an early insight for all of us, for early diagnosis of things, particularly those things that go across different specialties. The AI is really smart. That cognitive digital ability to go across, and really the biggest bridge from an interoperability perspective, I think, is connecting all of our health information on one side with all the medical knowledge of the planet and health knowledge of the planet on the other side. And that bridge is this still kind of going in and out? Am I okay? Yeah. And that's the bridge we need to strengthen. But this is an example of doing that. I mean, so certainly there are many other ways to just by having conversations with the AI, it's profound how many people that I have been able to help, just friends and family, that were not aware of the level of conversations that you can have about. And once you start using it and you're comfortable talking with the AI verbally, not just typing, I think that all types of health questions and health literacy can be addressed at a whole new level, as well as just the quality of life. It's not just your health, but it's the quality of your life. Just with being, just a little bit smarter. and feeling smarter and feeling like you're not alone, that you can actually consult the rich collective wisdom of the planet versus just consulting one other human brain. That's it's a really powerful thing. It's
Definitely. James, you referenced a second ago your paper, but want to walk through that just for a second. You wrote the paper regarding artificial intelligence and longitudinal health record. Walk the audience through kind of the finer points of your paper, especially what becomes possible when AI is added to the mix of a longitudinal record. Talk about ownership and talk about, the finer points of what your paper was trying to pass along.
So I'm interested, Linda, if you could share that example with me. I am always on the lookout for consumers using AI to help create a better or accurate diagnosis and maybe potential treatment. I do reference in the paper Courtney Morales Hoffman, whose son was failing to thrive and is becoming paralyzed. And anybody, I'm sure she's pretty famous now, she had seen 10 or 17 different doctors in 3 years and failed to get a diagnosis. And one night she plugged all of her clinical EMR data into GPT for a 4-hour session. And at the end of that prompt, or the series of prompts, the GPT came back with a possible diagnosis of tethered cord syndrome. She took that output to her clinician or primary care physician specialist. They confirmed he had the surgery to correct and now is thriving. And I think we think about that as a benefit or a tool or a positive reflection of AI, but I want to take a step back. And before we could get to that diagnosis from a misdiagnosis, Courtney had to aggregate her complete real-time, comprehensive, longitudinal health record from all the different various providers that she was seeing. As of now, the average consumer sees 28.4 providers in a lifetime. That number will presumably exponentially grow as consumers start to develop this participatory habit and active role in their outcomes or their healthcare. And I want to go back to the answer that Tom Loomis was asked about the future of LHR, the longitudinal health record. And I think it's a very important distinction that a longitudinal health record only exists in the custody of the consumer. There is no such thing anywhere else, despite seeing or spending or being a member of a particular payer or having most of my records inside one healthcare system or living in a certain state. If we just look at the missing contributed data that is already in the custodianship of the consumer, your wearables, your device data, your implants like continuous glucose monitoring, your social behavior, symptomology, your dietary, your family history, your imaging data that doesn't exist in the current form of the EMR and will never exist, even if we were living in North Korea, unless Kim Jong-il was feeding you the medicine, watching you eat, watching you exercise. There's no custodian of the complete real-time longitudinal health record besides the consumer themselves. So if we believe that good data, complete real-time data is going to help with diagnostics and therapeutics, then we need to unlock it and we need to go to the consumer. And Tom Loomis said that he doesn't see a future where that responsibility does not fully, and if I can paraphrasing, and hopefully, Tom, if you're in the room or listening, I'm not misquoting you, for the foreseeable future doesn't see that to be otherwise, where the consumer has to take action to aggregate all of the different clinical data from all the different providers that they are seeing, all of the contributed data, your imaging data, your wearable data, your social data, and bring it into one comprehensive, complete format. Fire APIs is something I'm particularly interested in because I believe it is the tool that we have at our disposal that will bring that to a realization for the first time in history, where I can connect the endpoints of the different hopefully we're there now, but I'm lucky. My boys are seen at major health systems. My youngest is part of the undiagnosed community. He's seen at Boston Children's, Yale, Cleveland Clinic, and NYU, all Epic, and all have working endpoints. But I'm able to aggregate all of that clinical data, the USCDI data, into one spot. I can add the imaging data. I can add whatever contributed data into one longitudinal health record format and plug it into a foundational model of my choosing. What API or Fire APIs give that some of the other lands or the tools at our disposal, like TEFCA or TEFCA IAS, or these health networks, is that I don't have to create a digital identity. I just have to have my portal credentials. I'm not really too concerned with portalitis. I think it's within the reason for us to expect consumers to remember their login and password for these portals. I think anybody that's looking to aggregate a longitudinal health record would already have that behavior in their purview. So I don't need to use a digital ID service like Clear at ID.me, and there's no patient matching issue. When I log into Boston Children's, Yale, or Cleveland Clinic, they're going to send me every piece of data on my son because I had that credentialized through the portal. Moreover, I think I heard this a lot earlier today, is that we're talking about the lack of technological savvy for some consumers to access. I think that comes down to simply that when we are looking at the most active consumers in healthcare, it could and generally be accepted that it's middle-aged children of aging parents that need a proxy caregiver to make care decisions, or a young parent of a sick child. So for me, Smart on Fires allow for Smart on Fire APIs allow for proxy access, and now I can, for the first time, I've done it multiple times using Smart on Fire APIs, create a complete real-time longitudinal health record for both of my boys, and I input it into basically every foundational model under the sun. I think it's important to build a process and have a front-end independent user interface that the consumer can engage with and either create summaries or harmonized records for human computability or for machines to look at. The future is here. We have the policy, mainly December 2023 API mandate. We have for the most part, the Smart on Fire APIs and USCDI to really create some progress or produce progress as far as leveraging all this data that is currently being siloed in different health systems and not accessible, to help us with precision medicine and translational sciences to better understand the biological form or population health. So what we should do is showcase or build these use cases around where this consumer behavior exists, how we leverage these policy tools, and how we leverage the technology. And I think that Rich Brennan said it from ALS, is I think that research is an optimal place to showcase that this is the universal behavior, not just because they have a rare disease or not just because they have a chronic condition. All 8 billion of us on the planet are going to take and have a responsibility to take an active role in our healthcare. So if that's the case, and if we are going to travel, or if we are going to reach a point in our existence, our evolution, where we travel with our complete real-time longitudinal health record, like a thumbprint, let's get there sooner. It might take 100 years, it might take 10 years, but there's no universe that does not see that the complete real-time longitudinal health record lives in the custodianship of the consumer. So what we need is to, prove that as soon as possible so we can start perfecting it and implementing it.
Sounds good. Linda?
Well, adding on to that, I certainly, over the past 40 years that I've been working in this field, there have been many initiatives that are related to this. I mean, certainly New Hampshire has the ownership of the electronic health record, but that's the only state legally where you own your own health information. But looking forward, there was the Open Notes initiative that started with Robert Wood Johnson that was incredibly helpful to start not just having access to limited structured data, but also to the various progress notes and other areas. Fast forward to today, think of that we do have a lot more access to our health information, and even if we don't have all the structured information, that we do have that ability now to leverage the various AI models to help us find insights. I think of AI as actionable insights, and I think that we're even moving beyond the era of using the term record and even electronic health records. I think it's had its day, and we need to move on to their platforms and their digital health journeys, and ultimately to be able to have that dashboard to really make effective decisions about the triage of care. And so many of us are not necessarily smart enough to know how to navigate the healthcare system. I think ultimately, from a policy perspective, looking at costs and even myself, I mean, that just the usage of emergency care, I think we can totally cost justify investments in many of these systems by more effective, care navigation that all of us are empowered to know. I look at the blizzard back east right now, and I think, what if we really had a much better connected care system where the West Coast could be helping out with virtual care teams of what's going on today? I think of myself cross-country skiing to get to Boston Children's as an ICU nurse back in the day, which I actually did. And I was there for several days during a similar blizzard to what we're going on right now. Many caregivers couldn't get to the hospital, and we were incredibly understaffed. But that half of what is done could probably be augmented with helping each other in virtual care teams if we had the right information. And then if all of us were smart enough to know when do we really need to go to the ER, versus when we can beam in some help. I just look at all the National Guard being sent to Massachusetts, but I was just thinking, I don't know, if you were pregnant and potentially giving birth right now, but couldn't necessarily, all the transportation systems are down. But maybe if you had a satellite to phone, that you could at least beam in help along the way. So I think we have so many puzzle pieces of care that just aren't yet connected to the point where it's not just workflow, but it's patient care flow. And it's not, sometimes we get buried in one diagnosis at a time, as opposed to really a much more holistic view. I think of it, I love the quote that I've heard of not that it's what's the matter with you, but what matters to you. Seems like that to me is missing sometimes. It's that the patient's story that doesn't necessarily come through in just the FHIR API structured data, because it's really very retrospective where it needs to be more prospective. What is your health priority list? And have a conversation about that as opposed to what's your problem?
Yeah. For those couple of folks here that said they use ChatGPT for their healthcare diagnosis, have you approached your physician with the information that you got from ChatGPT? How many of you done that? All right. Well, how was that interaction grade from 1 to 5? 5 being the best. Danielle has a thumbs down. I saw a thumbs up on screen. Charles
thumbs
gave me a
up.
thumbs up. All right.
All right.
So we'll talk about that real quick. So when you have that eventual interaction with the clinician and you bring up that, hey, I was just reading up on ChatGPT that I might have this. And so James, I'll start with you and then we'll go with Linda. What have you learned through your research about what was the past reaction, the current reaction, and what can you assume will be the future reaction for those physicians when a patient, a consumer, brings their ChatGPT diagnosis to the office?
So I think it's getting better. I'm not going to say that, and I think some providers and practitioners are very receptive, and I think that's the growing trend. I think, and it kind of, for me, the more astute the health system, the more open, or the more the higher the of skill the clinician has, the more receptive or open-minded they are for a consumer to come with some kind of homework, whatever it is, if it's with it, GPT-8, or if it's researching PubMed, or if it's referencing a specific paper. I think that the clinicians are more receptive than they were even 4 years or a few years ago. I'm not saying that there's a paternalism that still exists that is fighting that, but I think, I can reference a good example. My son, William, he has had a anteroventricular septal defect. He spent 3 months inpatient, was born at Yale, transferred to Boston Children's, surgery to correct there. He's failing to thrive now, and he has some neurological tumors. He's deaf, has some other tumors and anomalies that we're trying to figure out. And we sought out a specialist at NYU and sent all of the consent for portal access and all the US CDI and data transfers that we could sign off on. And we had an emergency telehealth conversation with the head of audiology and the neurosurgeon there. And when we went into actually physical encounter, we were being onboarded and talking to the PA, and she was asking questions, and I kind of stopped her for a second, and I had handed over my phone that had a summary of all of the conditions that she would, or of anything that might be interesting to her, specifically for the neurological tumors. And as I saw her pause and look at her monitor from the Epic dashboard and read my phone, it was as if she was being plugged into the matrix. And I could see her looking at the screen, looking at her phone, or her hand with my phone, looking on my phone in her hand. And then she was watching and confirming with what she read on the phone. And it appeared that we got ourselves to a level of understanding in a matter of minutes that might have taken the whole encounter. And then we were able to maximize her education experience, so she could start to put that into action as opposed to just getting herself up to speed. And I think an added interest in that, I can go back on Linda's comment about the expansion of, just what's in the EMR. There was a conversation or a comment that William's deafness might have been congenital. And I said to her, I said, I don't think that's true. And she said, yeah, based on everything that, we've seen and, all the scans and the assessment of physically looking at him, we think that he was born that way. And then I had to make the comment, then why did he pass his newborn hearing screening? And then they said, because they didn't have that data, because it's not part of the US CDI. Oh, that's true. then you're right. And that's part of like the gap between what data is being shared and what's not being shared. But the overall introduction or handing of the GPT summary, I think, made that engagement so much more impactful and powerful in the moment that we had with, her in that office and the neurosurgery team, that it seemed like it's being welcomed with open arms, more often than not. If I went back 5 years ago or 6 years ago with my middle son, there was a combative relationship that I don't see as much today. And the open-mindedness to allowing the consumers to help leverage the education experience of the clinicians.
Excellent. Thank you. I want to close with my final question. Those who listen to the podcast that we do at WEDI, the Collective Voice of Health IT, wait for applause. No. Okay. For that one, I typically ask my AI guests, 2, 3, 4 years down the line. I can't even do that anymore. I have to say 12, 18 months down the line. So I'll ask Linda to start off. We talked about AI, we talked about data, we've talked about the consumer being in the center of this care coordination healthcare journey. What do we see in the next several years or next couple of months in terms of the business model? Where will there be a shift, and who will be the catalyst for this shift? We're already seeing it, as James said, the kind of attitudes toward bringing ChatGPT information to a physician is improving, but where do we see this continue to go?
Yeah, I guess I do see this more as an evolution versus a revolution. And my website is renaissance.health, because I hope that we create a 21st century renaissance, and with all of the potential for the creativity, the curiosity, we just need a little courage, I think, to move forward with it. But I think we can imagine a world where more care comes to us versus us physically going to care. And that's going to be not just more efficient, but more effective, to the extent that, myself, as I'm getting older, that I can, be more self-reliant. I think most baby boomers really do want to be as self-reliant as possible. They just need to be informed as to, and I think that the new AI models, to me, it's just, I don't know, something I've been it was the future for the past 40 years, and it's here now. It really is up to us what we can do with these unbelievable, powerful tools. So it's not what the AI can do, it's what we can do with the AI. I guess I always start any sentence about the future with people, and the process, and not the tech will do this and the tech will do that, but instead it's not just human in the loop, but hopefully humans in the lead if we do this right. I think it's moving to being much more proactive, much more personalized. I always use the example, like we give out these incredible, patient instructions, or you get, this crazy med list, don't take it if you're pregnant, and you give that to an older man. Does that, do you really, can you search through what really is meaningful to me? And so I've worked with countless friends and family members over decades. Where just, introducing the internet and then introducing apps, but there's nothing like the personalization capability to make it really meaningful and understood, because it doesn't matter just to give patient education, is what do you do with it? And so you can absolutely personalize, be much more proactive, really look at all of this as an investment, not a cost to cut. People always look at technology as a cost and an expense, but truly look at it as an asset, as an investment. And the return on investment, I think, will be quite solid, and the value will be very solid, because it really can now be personalized.
Excellent. James, I'll give you about 45 seconds.
I think that it's incredibly exciting. I think we have the future. It's just unevenly distributed. What will inevitably suss itself out is the the way that we aggregate all this data. We just need a consumer interface. It's not going to be an EMR vendor. It's not going to be a health system. It's going to be some kind of independent interface, and it could be taken on by Anthropic or an OpenAI or one of the large language models. But what we will need is early adopters to understand where the gaps of technology, even policy. I think it's a big hurdle that we need to overcome is the information blocking and making sure that these API endpoints are created, maintained, and accurate for us to connect to. And I think the National Provider Directorate, CMS, is a big step in innumerable measurement to enforce that, not just with the large systems, but making sure that the smaller institutions and health systems or providers are creating these endpoints. And then once we start to implement that among these early adopters like research, and I particularly think that it's rare congenital genetic research, because these are the people that know that there's not teams of resources at their disposal or researchers or investigators working on their behalf. They need to leverage that intention and time that we can implement these APIs. We can see if there's blocking, if the endpoints are working correctly, how we harmonize it into a computable format, where it's stored, what's the consent management, and then ultimately how we leveraged large language models and how accurate they were and what they were producing for us to create new novel discoveries of that particular cohort, and then refine it into a duplicatable process to share amongst other research objectives, and then ultimately roll out into the general population. And for me, that's the biggest mission for anybody to spend, is these early adopters get these APIs working, get this harmonization, get this large language model integration into practice, so we can start to develop new and better policy tech standards. Then we can start to make sure that it's ready for prime time for anyone that wants to use it for precision medicine and translational science. And that's basically what participatory health was created to do.
Excellent. Thank you so much. James, Linda, thank you for this fantastic conversation.
Thank you.